Hi, good afternoon, everyone. Thanks, PGLDS and the organizing committee for giving me a chance to talk on infections in post liver transplantations. I will try my level best to justify with the topic, and without wasting time, I will just start with an overview of infections in liver transplantation. Liver transplant is considered as the standard of care for decompensated liver disease, not only for DCLD, but acute liver failure, acute and chronic liver failure, liver cancers, and and certain metabolic disorders. Patient and graft survival have increased with improvement in surgical techniques and postoperative management, particularly with respect to immunosuppression. However, despite many advances in the field, infection remains a leading cause for morbidity and mortality of the patients. Risk of infection after liver transplantation varies with time, which is usually a reflection of burden of immunosuppression and allograft function. Post liver transplant infections are estimated to occur in more than 50% of liver transplant recipients. Bacterial infections account for most post transplant infections, then followed by viral and fungal infections. Fortunately, due to intensive screening practices to detect latent infections in liver transplant candidates, and with the implementation of appropriate prophylactic therapy, mortality associated with post transplant infections is low and has been documented to be less than 10%. The risk of infection post liver transplant is primarily determined by epidemiologic exposures, which include donor derived and recipient derived factors. Those are also associated with the healthcare acquired pathogens, community acquired pathogens, and patient's net state of immunosuppression. Then the net state of immunosuppression is based on multiple factors, which include level of pharmacologic immunosuppression, underlying host factors, surgical procedures, and other medical interventions that a patient undergoes, and viral infections such as CMV. Actually, this is a complex interaction and it generally varies predictably over time based on typical protocols for anti rejection immunosuppressive therapy and prophylactic strategies. Other factors known to increase the risk of infections after liver transplant include pre transplant sodium malus score of less than 30, need for second operation after transplant surgery, post transplant renal replacement therapy requirement, intensive care stay longer than 48 hours. It is the standard of care to obtain a good history, perform a thorough physical exam, and order comprehensive infectious disease workup in all solid organ transplant candidates, including liver, kidney, pancreas, heart, and intestine. These steps allow a clinician to identify active infections that would require therapy prior to transplantation, identify latent infections that can reactivate after transplantation, and assess the need for vaccination to reduce the risk of de novo infections after transplant. This is the timeline which most of the centers follow, that which infection is to occur in first month, which can occur in 1 to 6 months and beyond 6 months. That's early, intermediate, and late complications or infections, which I'm going to discuss further in my coming slides. As I mentioned, in early phase, the early infections that occur range from the time of surgery to 1 month post transplant. Intermediate infections range from 1 month to 12 months post transplant, and the later those which occur beyond 12 months post transplant. When we talk about the early infections, since the full extent of immunosuppression is not achieved within the first month, infections are most often nosocomial and bacterial in origin, similar to the infection which occur in immunocompetent hosts undergoing other hepatobiliary procedures. These are more common in patients with significant lengths of stay in hospital before transplant. Opportunistic infections are less likely to occur in this period unless the patient was taking immunosuppressive medications pre-transplant for underlying autoimmune disease or in the setting of retransplant for graft dysfunction. A variety of factors are associated with an increased risk of bacterial infection, which include older age, length of preoperative stay, CME infection, duration of surgery, retransplantation requirement, volume of transfused blood products, preoperative MELD and CTB score, bilioenteric anastomosis, technical complications like biliary leak, hepatic artery thrombosis, renal replacement therapy, which I've already discussed, and hypoglycemia. Intra-abdominal infections are most common due to the technical nature of the surgery. A 30-year review at one of the centers found a 14% rate of biliary complications post-liver transplant, including anastomotic and non-anastomotic strictures, bile leaks, and cholangitis. Elevated MELD score, hepatic artery thrombosis, and elevated donor creatinine suspected to reflect altered metabolic factors at the site of anastomosis, which may impair healing, were also significant risk factors for anastomotic biliary complications. Biliary complications may in turn lead to further infectious complications such as hepatic and intra-abdominal abscesses. A 10-year retrospective study at a large center diagnosed hepatic abscess post-liver transplant at a rate of 4.8 per 1,000 per year. After intra-abdominal infections, the lungs are the second most frequent site of infection complications post-liver transplant. Both intra-abdominal infection and pneumonia can be complicated by concurrent bacteremia also. Surgical wound infections are the third common infectious complications during this period, followed by UTI and healthcare-associated infections. Risk factors identified for surgical site infection include prolonged operative time, large volume blood transfusions, biliary leak, retransplantation, dialysis, and CME infection. Prophylactic antimicrobial therapy is universally used in the immediate post-transplant period to reduce the incidence of bacterial infections. The selection of an appropriate antimicrobial agent is typically guided by the local epidemiology at every center. Transplant prophylactic antibiotics should not be used beyond 48 hours post-transplantation. This is just, I'm talking about the prophylaxis, but it can vary also from center to center and from region to region. Prolonged use of broad spectrum antibiotics without evidence of an active infection is always discouraged. Antifungal prophylaxis in solid organ transplant recipients remains a complex and controversial issue. A targeted prophylactic strategy is used to prevent fungal infections. Fluconazole and echinocandins are both used for targeted prophylaxis, but the latter have become the leading choice as they have fungicidal activity and prevent against fluconazole resistance, Candida species. Candidates for targeted antifungal prophylaxis include patients with prolonged and complicated liver transplant surgery, patients who have received multiple blood products, which I've already mentioned, and the patients with renal insufficiency requiring RRT, that is renal replacement therapy. In high-risk patients, antifungal prophylaxis is recommended for 7 to 14 days after solid organ transplants. When we talk about intermediate phase or the duration ranging from 1 month to 12 months post-transplant, the risk of opportunistic infections is highest in the first year after transplant, particularly between 1 to 6 months, as the recipient is tapered down on the immunosuppression to a stable maintenance regimen. This was the period in which the classic opportunistic infections, including PJP, CMV, and herpes simplex virus, were recognized to occur earlier. With both improved recognition and advances in the diagnosis and prophylactic therapy, these pathogens occur later or atypically in current area of transplantation. In addition, new pathogens like C. diff and multi-drug resistant organisms have taken their place. Complications from HBV and HCV can also occur during this time frame. Now, coming to the CMV, which can also occur in this period, despite the medical advances, it's still the most common virus to occur after liver transplant with significant impact on morbidity and mortality of the recipients. The risk is highest for those recipients who acquire infection at time of transplantation from their donor. Because of the lack of existing cell-mediated immunity necessary to control the infection plus implication of acquiring an infection and setting up immunosuppression. The risk is followed by the risk is followed second by CMV recipient positive patients. Then CMV donor negative and recipient negative have the lowest risk as they must acquire the infection from new exposure in post-transplant patients. Period. The estimated incidence of CMV infection in the first 12 months after transplant ranges from 44 to 65% for the highest group, and then it goes down. Prophylaxis reduces the incidence but does not eliminate it. Immunosuppression, particularly lymphocyte depleting agents, viral co-infection, and allograft rejection also increase the risk of CMV occurrence. CMV has both direct and indirect effects on patients' post-transplant course. Direct means the occurrence of clinical symptoms which are associated with CMV, signs and symptoms, I mean to say. Indirect effects of CMV refer to those changes in the host that occur as a result of viral replication. These include immunomodulation leading to increased immunosuppression, oncogenesis, or allograft injury. In liver recipients, CMV may give rise to bacterial or fungal superinfection, EBV associated post-transplant lymphoproliferative disorder, acute or chronic allograft rejection, and vanishing bile duct syndrome or ductopenic rejection. CMV infection is an independent predictor of mortality post-liver transplant, with one study quoting five-fold increase of all-cause morbidity, all-cause mortality, and an 11-fold increased risk of infection related to mortality. Diagnosis of CMV has improved dramatically. Serology is the only useful for determining risk pre-transplant. Post-transplantation, viral load detection has become the standard of care as it is the faster and more sensitive than additional viral culture. There are two approaches to prevention of the CMV disease after liver transplantation, which is prophylactic antiviral therapy and another is preemptive therapy. At most of the centers, the practice is to go ahead with the preemptive therapy, which aims to detect CMV viremia before clinical disease manifests. CMV occurring after liver transplantation is treated with IV ganciclovir or valganciclovir. Then the second line drugs we have is foscarnet and cidofovir. When we talk about the PJP, which is a dread complication in the patients who encounter, it is actually a ubiquitous fungus that causes acute lung injury in immunocompromised hosts. A recent review found that the incidence in liver transplant recipients ranged from 1 to 11% in larger studies of patients not on prophylaxis and 0 to 2% in patients on prophylaxis. Unfortunately, the mortality rate for patients who develop infection is high, from 7 to 88%. The major risk factor for PJP in liver transplant recipients is the burden of immunosuppression, particularly steroid dose, and induction with lymphocyte depleting agents or alemtuzumab. Comorbidities such as allograft rejection, neutropenia, low CD4 counts, and concomitant infection, specifically CMV, are also associated with increased risk of PJP. Although most infections occur within the first few months of the transplant, later infections due to outbreaks are also mentioned in the literature. Septra is both the treatment and prophylactic agent of choice for PJP, generally, which is recommended for 6 to 12 months post-transplant. This is what prophylaxis is. Dapsone or inhaled pentamidine are the preferred alternatives for patients who are intolerant to Septra. PJP can be diagnosed on the basis of PCR and immunofluorescent staining. Diagnosis is most sensitive if both bronchial lavage and transbronchial biopsies are taken or multiple respiratory samples are obtained. Liver transplant recipients who are suspected to have PJP should be started on Septra as soon as possible. If confirmed, the optimal duration of Septra is extrapolated from HIV patients where 21 days is typically used. Adjunctive corticosteroids are recommended for moderate to severe PJP within 72 hours of initiating antimicrobial therapy. Regimens generally include prednisone 40 to 60 milligrams twice daily for 5 to 7 days, followed by taper afterward. Tuberculosis. WHO estimates one third of the world's population being infected with Mycobacterium tuberculosis, mostly being latent, with the risk of reactivation and active disease in the setting of immunosuppression post-transplantation. The biggest risk factor for accusation of disease is the country of origin, because in a lot of countries it's still endemic disease. Risk factors for reactivation include concomitant infections such as CMV, allograft rejection or dysfunction, and renal failure. The estimated incidence in liver transplant recipients is approximately 500 cases per 1 lakh recipients per year, with a prevalence of 1.3%. Most of these infections occur in first year post-transplantation, typically between 3 months to 12 months. Pre-transplant evaluation for latent TB in transplant candidates is considered a standard of care. However, there are challenges with diagnosing latent TB in setting of ESLD. A comprehensive evaluation includes assessment of risk factors, a chest X-ray, and some form of testing for TB exposure. Although PPT or interferon release assays perform well for detection of latent TB in otherwise healthy subjects, these tests perform less well in liver transplant candidates because of inertia due to liver dysfunction. In addition, we still lack a gold standard for diagnosis, leaving the sensitivity and specificity of results questionable and making it difficult to declare best test to use in pre-transplant setting for these patients. Although active TB typically presents as a pulmonary disease, liver transplant recipients are more likely to have disseminated presentations. Approximately two-thirds of the patients, post-transplant patients, TB has been reported to be extrapulmonary. When a TB is diagnosed, the standard of therapy is to start with 4 drugs and then continuation of the 2 drugs. In transplant recipients, drug interactions between rifampin and CNIs are significant, and rifabutin or another alternative may be substituted. Duration is tailored to the site of infection and clinical response. Resistance has become an issue in some countries, leading to alteration in therapy. Transplant candidates who are found to have latent TB are ideally treated pre-transplantation. The therapeutic options for latent TB infections include isoniazid daily for 9 months, isoniazid rifabutin weekly for 12 weeks, and rifampin daily for 4 months. Now coming to the late phase, beyond 12 months post-transplant. As the patient gets further from the transplantation procedure, the risk of infection diminishes, and other complications such as malignancy become more common. Late in the post-transplant period, recipients are at risk for typical community-acquired infections such as community-acquired pneumonia and influenza, or complications from end organ disease if they have allograft dysfunction. Less common are the opportunistic infections such as aspergillosis, cryptococcosis, and PJP. In patients who experience allograft rejection requiring increased immunosuppression, their risk for infection returns to that of the immediate post-transplant period, actually. The evaluation and management needs to be tailored accordingly. CAPE occurs in significant portions of patients in late phase after liver transplant. It occurs in 19% of patients diagnosed with late infection in one series, nearly equal to the risk of cholangitis. Herpes zoster is a very common late post-transplant complication. One observational study found that 12% of their liver recipients developed herpes zoster at a median of 23 months. Liver recipients with zoster should be treated with appropriate antivirals, which include valsacrovir, acyclovir, and famciclovir. All are appropriate oral agents with IV acyclovir for those with complicated or disseminated zoster. Finally, coming to the conclusion, despite advances in the field of transplantation, liver transplant recipients remain at risk for a variety of infectious complications. Comprehensive pre-transplant infectious disease workup, immunization, and perioperative and prophylactic antimicrobials are vital to decrease the rate of infections after liver transplant. An understanding of intricacies of these post-transplant infections and continued development of preventive diagnostic and therapeutic interventions aim to provide further improvements in outcomes following liver transplantations. Thank you so much.